at the question of osimertinib alone or with stereotactic radiosurgery. So these are our disclosures and how we plan to mitigate bias. And I think the objectives of the study is just to briefly review the burden of brain metastasis in this EGFR population, which I think is a little bit different than the general lung cancer population based on the longevity of these patients. And then discuss the rationale between why we decided to embark on this study to compare osimertinib alone versus with stereotactic radiosurgery. And then finally, a brief discussion of some other targeted therapies that have some emerging evidence for management of CNS disease. And so I think I'll start with really what we saw as the scope of the problem and why we kind of figured that this was a question that really needed answering. And many of you may be familiar with this pie chart, which looks at molecular characterization of non-squamous non-small cell lung cancer. And you can see that the vast majority of this pie chart is occupied by two mutations, KRAS, which we'll chat a little bit about later, as well as EGFR. And EGFR sensitizing mutations accounts for about 20% of this pie chart. But of course, that number is going to vary depending on the population that you serve. And in Vancouver, we have a very high Asian population, very high non-smoking, never smoking population. So our numbers are probably a little bit higher than that in comparison perhaps to our more northern colleagues in the province. And so we have been testing for EGFR mutations since March of 2010. And that's because, of course, the first generation gefitinib was approved and funded for us in October of 2010. Prior to that, we were using the patient support program that was offered by AstraZeneca. And then I think the data kind of marched on pretty quickly. We got access to afatinib in 2014, which is a second generation drug. And then we had access to osimertinib in the second line setting with the development of a resistance mutation, T790M, in October of 2018. And then finally, the first line data was funded in January of 2020. So we have been treating patients with these EGFR mutations for over a decade. And so, of course, as you're doing that, you start to have very different questions that arise as you are taking care of your patients. And so this was a study that we did in BC, looking at the incidence of CNS metastasis, both in EGFR mutation as well as wild type non-squamous non-small cell lung cancer. And it was a 2-year cohort from 2010 to 2012, really looking at some factors for consideration of development of brain metastasis. And I think what you can see certainly on the forest plot is that if you had EGFR mutation positive disease, if you were younger, you were more likely to develop CNS disease. And so we did a competing risk model that you see on the right side of your screen and decided to look both at mutational status as well as age. And we chose 66 because that was the median age in our population. So we thought it divided the population quite nicely. And what you can see is that if you were younger and you were EGFR mutation positive, the 3-year cumulative incidence was almost 60%. And if you were older and EGFR positive, that rate was still about 20%. So that certainly this affects a significant proportion of the population that we were treating in BC. And then we kind of said, well, okay, we recognize that we have a lot of patients that are diagnosed with CNS metastasis. What does that mean for their outcomes? And so this study was also about a 2.5-year cohort, sort of overlapping the prior study. All of these patients had brain radiotherapy and had brain metastasis. Almost all had whole brain radiotherapy because of the era that we were talking about, like a handful had SRS. And so if you look at the top two figures, those are patients with EGFR wild type disease, so the general lung cancer population. And so for patients who developed early brain metastasis, and we define that as within 6 months of diagnosis of lung cancer, and just use that as a pragmatic definition simply because, of course, sometimes it takes a while to get all the investigations sorted for the patient. So if you had early brain metastasis, that was really survival defining, with a median of 7.1 months. And that is from diagnosis of cancer on the left. And then on the right, with the green and blue bars, that was the overall survival from the time of brain metastasis. So it appeared that brain metastasis really was kind of defining for what happened to those patients. On the bottom two graphs, these are EGFR mutation positive patients. Again, all of them have had brain radiotherapy. If they had early diagnosis of brain mets versus late diagnosis of brain mets, you see that those overall survival curve from diagnosis kind of, there is a separation, but they kind of come a little bit closer together in comparison to the first set. Although you do see for overall survival from the time of brain metastasis diagnosis in the green and the blue, that again, diagnosis of brain metastasis in the late setting was definitive really of overall survival. And I think this difference in the shape of the curves probably reflects that CNS penetration, even of the earlier generation TKI. So this was in the era of predominantly, gefitinib, essentially, therapy, so that there was certainly some penetration, and that could potentially benefit our patients. And of course, recognizing the impact on the incidence, the impact on survival, we also ask the question, well, if you get brain metastasis, what is that going to mean in terms of health resource utilization? And so this study was really looking specifically at EGFR mutation positive patients only. And we looked at the patients who had brain metastasis and saw that from the time of brain metastasis to the time of death the median was 9 months. So we took the EGFR mutation positive patients who did not have brain metastasis and counted back from time of death 9 months so that we could accurately compare what end of life resource utilization would look like. And what we saw is that in terms of clinic visits, hospitalizations, and ER visits, that they were certainly significantly higher in those patients who had CNS metastasis. And you can see the fold increase in that last column. Of course, more radiographic investigations, I think that kind of was certainly to be expected, and actually more hospice admissions. The PCU admission rate was the same, and in BC, PCU admissions are really about admissions to hospital, where the expectation is you might be able to improve symptom management and then be able to discharge, whereas hospice is really directed at end-of-life care. So I think with all of this data, we were learning a lot about what having brain metastasis with EGFR positive disease could mean for our patients. The incidence was high, and if we look at other real-world studies, that incidence in this population is again in that 40% type of range. So a significant population. That the development of brain metastases in the course of the disease also has a significant impact on survival, speaking potentially to the treatment options available. And of course, the health resource utilization really reflects, I think, the patient experience. There's a significant symptom burden that patients were seeking medical attention for, and certainly a detrimental effect to their quality of life would be, I think, reflected by that health resource utilization. So we knew that this was a big problem. And so I think that led us to our next steps, which I'm going to hand over to Shilo now.
Great. Just share my screen here. So are you seeing something that looks like a PowerPoint presentation?
Not yet.
Oh, not yet. Okay, hang on one second. How about now?
Yes.
Oh, great. Okay. Just a little bit more background in terms of where we were in terms of why we wanted to do this. One of my big motivations was what we were seeing in clinic. This is just the schema for anybody who wasn't participating in the trial or know about the trial. So this was a case that I'll just never forget. It was a woman who was EGFR positive, was diagnosed with stage 4 lung cancer, had some palliative radiotherapy to the chest, and then got started on gefitinib. And somewhere during the course of her treatment, a surveillance CT head was done, and 10 tiny brain metastases, like you see here and here, were identified. She was asymptomatic and there wasn't any peritumoral edema. And so it was really hard to know, how long were they there? And maybe they were actually being treated by the gefitinib. So the decision was to just continue on the gefitinib. And part of the reason for that is because at BC Cancer at that time, we were really only giving SRS for patients with up to 3 brain metastasis. So this woman would have been recommended whole brain radiotherapy. So she came back for her next CT scan, and at the visit, the oncologist had actually noticed that she had drawn her eyeliner on her cheek. And her CT head showed, unfortunately, innumerable tiny brain metastasis, and that's when she was referred to me. She had short-term memory impairment. She was ataxic. This was when I gave her whole brain radiotherapy, and during her radiotherapy, she actually wasn't able to feed herself anymore. And then she became completely dependent for self-care by the time radiotherapy had finished, and she passed away just two weeks later. So I was really kind of tortured by this case, to be honest with you, and it made me really wonder, does TKI alone have the same intracranial control? Does it have the same survival? And does it really lead to improved neurocognitive outcomes and quality of life if the aim is to do that by delaying radiation? And, I found myself asking, what is the standard of care here? And there was this real campaign of delaying the rays when we started seeing brain response to TKIs, but the evidence for that was really of low quality at the time. So we had this pooled analysis of AURA 1 and 2, which was the studies that looked at osimertinib in the second line study for EGFR positive. I'm just in the middle of a talk right now, okay? You just gotta go see daddy. You gotta go see daddy. Okay, I'm very sorry. Just 1 second, Olivia. Ben. I am so sorry about that. There's like a CNN news visitor or something about that, but anyway, okay. So basically, all the patients with brain metastases ended up getting pooled to assess their response, and over 50% of them actually had a response to the osimertinib. The catch to that is actually 75% of them had prior brain radiotherapy. Then we have FLORA, which was actually the assessment of osimertinib in the first line setting for the management of patients with EGFR positive cancer. And similarly, we saw really exciting intracranial responses with an overall response rate of 66%. And 25% of those patients had actually had prior brain radiotherapy. There was also a retrospective study. This was a 6-center study with, I think there were over 200 patients in this trial. Actually, it was 350 patients in the trial. And what they looked at is people who got SRS or TKI or radiotherapy for the management of their brain metastases. And the patients who got TKI alone had worse intracranial progression and also inferior survival. So this was kind of an alarming retrospective study. In my mind at the time, the standard of care for these patient population was still local therapy, whether it be surgery, whole brain, or SRS. And at the time, I was really junior in my practice. I think I was in my second year, and I found myself wondering, what did we do in the past when a new therapy had come on the horizon that was showing kind of exciting results and was clearly less toxic when what the standard of care treatment was. And I think a really good example of that was the development of SABR for the management of early stage lung cancer. And so when we started seeing promising results in our prospective trials, what did we do? We didn't start a hide the scalpel campaign. We did more studies. We did more prospective studies. We tried to do a ton of randomized trials that just failed to recruit, and we're still trying to do randomized trials. And to this day, we still say that surgery is, the standard of care for patients who have operable lung cancer. So it was really, a combination of what we were seeing in the clinic and a desire to really kind of stick to the science, which led us to this trial. And there was also a whole bunch of luck in terms of AstraZeneca coming to the oncologist at Vancouver Cancer Center saying, we want to do some kind of study in looking at the management of brain mets with osimertinib and radiotherapy. Is there something that you guys could pitch? And I think, the luck for me was that Cheryl was willing to take me under her wing to really develop a study like this, because I had no business in clinical trial development at that point in time. So I have 5 lessons learned. The big one is, there's the trial that you want to do, and then there's trial that you can't do. And this was a famous rectal cancer trialist that made this statement at a meeting, and it's really resonated with me. So these were the primary endpoints for our trial: intracranial progression-free survival at 1 year, and then the secondary endpoints that are listed here. And if we did the trial that I wanted to do, my primary endpoint would have been either neurocognitive function or quality of life. And the reason for that is because that is the primary reason why we talk about delaying radiotherapy in these patient populations. So that's the question that I wanted to answer. But practically, the number of patients that you would need to be able to do a study like this is not something that we would have been able to do for an investigator-initiated trial. The other thing that I would have liked to have done would have been for the assessment of our neurocognitive endpoint, which actually do a cognitive battery of tests instead of the MoCA. And in the original trial development, David Schultz had connected me with his neuropsychologist over at PMH to try to figure out, what we could do. And it just wasn't feasible for us from the kind of training of a staff point of view to be able to deliver these tests, and from a funding point of view to do that. So we stuck with the MoCA. The other thing that I wouldn't do is look at intracranial overall response rate, because we know with SRS, brain mets don't disappear. So we know that osimertinib is going to be superior in that regard. And so I don't think it's a relevant clinical endpoint, with the exception that I think having a purist overall response rate for patients who have not previously had radiotherapy is an important mark in the literature to document. The second lesson is your inclusion and exclusion criteria. You develop them because you're trying to have a pure trial, that's not going to be criticized in the future, but these will work against you in recruitment. So my advice is to really consider the rationale behind each and every one of those, and ask yourself, what is the spirit of the trial? What clinical question are we really trying to answer, and are these absolutely necessary? So I've got 2 examples for you. So currently our trial is open to patients in the first or second line setting for osimertinib, but that's not the way that our trial protocol was written. And so we opened the trial just after osimertinib had come online as a first line therapy. And so we had this giant cohort of patients who were on erlotinib and gefitinib. They were progressing in the brain. They had a T790M mutation, and they were, could be eligible for our trial because they were going to start osimertinib, but the protocol didn't allow it. And so we ended up revising the protocol. And by the time we got that pushed through, I would say that wave of patients had kind of passed. So I'm not sure that we were really able to recruit anyone with that change in criteria. The other one, the revision, is a credit to Arjun, because we previously did not allow for surgery. And when we were having difficulties with recruitment, Arjun, had kind of said, look, like, I've got lots of patients with multiple brain mets who might have one resected, and then I go give them SRS. And so we revised that criteria, and that has led to increased accrual. The other thing is, you have to remember the population that you're serving with this trial and what the real practice environment is in your criteria for the timing of the investigations and things that you're designing, because again, that's going to work against you. So if we think about the patient population, these are patients who have newly diagnosed stage 4 lung cancer in the most cases, and it's spread to their brain. They're really worried. A lot of them have symptoms from their extracranial disease. A lot of them have experienced delays in their workup, and they are waiting for the molecular information to know if they have an EGFR mutation for which they can get a miracle drug to treat their lung cancer. And then 2 to 3 weeks later, they find out that they have this mutation, and now they're eligible for a trial. But you might have to go get an updated CT and MRI. And if you get randomized to the radiotherapy arm, you actually can't start the miracle drug until after the radiotherapy is delivered. So, I ask myself, I think this is very classic trial language, but would it have been a big detriment to the answering of the question if we had allowed, a CT within 6 weeks, for example, because you're going to get updated imaging of the brain for your radiotherapy planning anyway? And would it be a problem if you started osimertinib as soon as you were randomized, held it for the RT, and then started it again? Because we definitely lost patients because of this. One thing that we did right is the radiotherapy protocol in terms of doses and the machinery that can be used was written with flexible language. And this was done with the efforts of Alan and Arjun and David. And I'm very grateful for that because it made the trial pragmatic. The other thing, big important lesson, is if you do not have a novel therapy, recruitment is going to be hard. And there are going to be unexpected challenges that are going to slow your accrual in what you have imagined. So osimertinib was approved prior to us going live. And people at our center knew that this trial was coming, and we would literally get emails from oncologists saying, my patient would be eligible for your trial. When are you opening? Because I'll wait so that they can get osimertinib. And then as soon as, it went, osimertinib was approved and then we went live, that incentive was gone. And then of course, a couple months later, we ended up getting Sunnybrook and PMH online. And then like everybody else, we got hit with COVID. And then a year later, we, launched this EMR that delayed our abilities or kind of strained our abilities to get people onto clinical trial because of everything else that you're dealing with at your center. So because of that, you need to be really careful in who you are collaborating with on your trial, because the only person who cares about your trial is you. And this is something that Alan Netko had said to me in the hallway, one day, and it really resonates because you are going to have challenges. And so what is it that you're going to do to really hit the ground and work as hard as you can to get people on your trial? So you need to advertise it locally, regularly, to your community sources of referral. You need to advertise it to the other sites that are participating with you. And to be honest with you, on reflection, I wish we had given this, a year or two ago at PMH and Sunnybrook. And then you need to come up with a system for screening eligible patients. And so what we did is, for every patient that was referred to our center with stage 4 lung cancer, we would screen them and we would see, do they have brain mets? And then we would hang on to them to see if they had an EGFR mutation. And we would, contact that oncologist and say, look, they're eligible for our trial. And then we ended up getting ethics approval for notification of every single EGFR diagnosis in the province. And so then we would screen them, and that really helped with recruitment. And it served as a reminder to oncologists, that, this trial is still running and it's important. And I think you have to have a plan B. What are you going to do if you don't hit your accrual number? Are you going to bail, or are you going to try to do something with the data that you've achieved? And our plan B is collaboration with Outrun, which is a study that's being run by the TROG group. It is a study which was designed completely independently of us, and very similar in that it's randomizing to osimertinib SRS versus osimertinib, patients who have brain mets that are asymptomatic, and looking at the same endpoints. So both of us were having difficulty with accrual. So the idea was, instead of us aiming for 76 patients and them aiming for 80, we're each going to aim for 40 and try to pool our data and still answer the question, which I'm super excited about. So where are we at? Thanks to Sunnybrook, as of yesterday, we have 36 patients, so just 4 more to go. So really looking forward to finishing this trial and trying to answer this really important question. Thank you, and my apologies for the surprise appearance.